Welcome to this CSRT e-course. It's with great pleasure that I introduce today's presenters. Emily McMullen has many years of clinical experience as a respiratory therapist, working in various roles in acute and complex continuing care. In 2009, she developed a keen interest in chronic long-term ventilation and focused much of her time towards this unique patient population within a complex care facility. In 2018, Emily began working with Somerset West Community Health Centre to develop the complex respiratory care program. Maynard is a registered respiratory therapist, certified respiratory educator, and fellow of the CSRT. Michelle's been an RT for 23 years and has had the pleasure of working across multiple provinces in acute care and community care. Michelle is the manager of the lung health program at Somerset West Community Health Centre and has been since 2015. Michelle is also the RT representative at the Champlain Regional Incident Table for COVID-19. Welcome to both of you.
Thank you, Carolyn, for the kind introductions, and to the CSRT for inviting us to share our learnings for respiratory therapy outreach during COVID-19. We've had the great opportunity as a profession to hear about the remarkable work our respiratory therapy colleagues are doing in critical care in response to the COVID-19 pandemic. Today, we're hoping to share some of what we have learned in the community and the considerations that need to be taken while continuing respiratory therapy outreach in the midst of a pandemic. While COVID-19 continues to result in prolonged periods of increased demand on our healthcare system, it is essential to maintain our vulnerable complex respiratory care clients in the community and out of the tertiary care centers where at all possible. In doing so, we're able to help maintain capacity in our already stretched healthcare system. It is imperative that all levels and parts of the healthcare system come together to coordinate efforts across the continuum of care for these clients. The coordinated care ensures an effective and safe transition from hospital or subacute care setting, home, or the ability to keep a client currently living in the community out of our already maxed tertiary care centers. Today, Emily and I will provide a brief introduction of the complex respiratory care program hosted by the Somerset West Community Health Centre and the client populations we serve. I will highlight the importance of a point of care risk assessment, and for those therapists doing outreach, this is in fact begins even before we enter the home. I will discuss how COVID-19 pushed the program to leverage virtual platforms, facilitating ongoing care in the midst of a pandemic, and the importance of creating a menu of virtual options to meet the client's needs. We will highlight some of the factors that have impacted the change and how not only having to enter a client's residence, but how our practice has changed in response to the local public health recommendations. We will discuss PPE in the outreach setting, including the differences in terms of donning and doffing PPE, the disposal of PPE once leaving a client's residence, and the preparation required before heading out into the community for the day. COVID-19 has not only had an impact on us as therapists, the pandemic has had some big implications in terms of care delivery for our clients, and there has increased the burden of care on our caregivers, especially the unpaid caregivers in our area. I will touch on the importance of reviewing your current policies and procedures to take into account your change in practice and the need for those policies to comply with the college regulations in your province. Lastly, we will highlight some of our lessons learned thus far. Hospitals certainly have had their own set of challenges. However, primary and community care have also encountered new challenges. Outreach services have certainly changed for many of the RTs, and for some, perhaps, home visits ceased completely for a period of time. For others, home visits may have resumed, however modified, and for others like us at the Somerset West Community Health Centre Complex Care Program, we've been deemed essential service from the get-go back in March and have not stopped. This has resulted in a host of new protocols being put in place. Outreach services may continue to vary across the country as the community transmission rates rise and fall over time. The Complex Care Program is a primary care-based respiratory therapy outreach service hosted through the Somerset West Community Health Centre. The CRC program provides service across the Champlain region. This is a large geographical area that shares a 465-kilometer border with Quebec. Outreach visits have increased in complexity in light of the pandemic. This includes everything from the discharge process to training new staff, to the complexity of clients themselves returning home. We are optimistic with the vaccines in our not too distant future. However, we know that it will be some time before vaccination is available to the community at large. And in the meantime, we must strictly adhere to the necessary infection prevention and control measures. I'm going to share a bit of the objective of our program. So the objective of the complex care program is twofold. We support complex care clients currently living in the community and help them stay in the community. And two, we facilitate a successful transition from hospital to the community from either this acute or subacute care setting, if that is a goal of care for the client and their families. Once in the program, the Complex Respiratory Care Program provides ongoing support to clients, caregivers, and nursing agencies providing the day-to-day care. What are these outreach patient populations? So these can include those who require home oxygen, those on sleep therapy, and the population here for our Complex Respiratory Care Program, we focus on the complex respiratory care clients. These clients include tracheostomy patients, ventilator-assisted individuals, both invasive and non-invasive, or those requiring secretion clearance devices such as cough assist. Many of these clients are the most vulnerable as they are living at home or in an assisted living residence with a large portion of the care coming from unpaid caregivers. For those who have some publicly funded agency care, they may now, in light of the pandemic, have a decrease in hours of service that's available to them. This is due to a huge human resource shortage. This can include staff illness, or families simply choosing to minimize staff coming in and out of their homes to eliminate the increased risk of community exposure to COVID-19. What has been our COVID-19 response? Well, as we mentioned, our health region deemed the program essential, and keeping these clients home is perhaps more important now than ever before. The abrupt changes in services resulted in service providers needing to modify and pivot services to ensure safety to both staff, clients, and their caregivers. The use of various technologies is not new for many of our client population. Many ventilated clients require the use of technology for communication prior to COVID, which has allowed the respiratory therapists to leverage this platform. The need for staff training was evident. Many families have agency staff assist with a variety of care needs. However, as the community transmission rates rose rapidly in our area, there was a significant HR impact for nursing agency staff. New nursing or PSW staff coming in required training, and the Complex Respiratory Care Program had to adapt services to minimize face-to-face time, maintain social distancing, and limit number of people at the bedside. Certainly, at the onset of the pandemic, when there was little known about COVID-19, a new triage process was required on our part, and where possible, virtual visits were used to determine if an on-site visit was required. Infection prevention and control measure recommendations were strictly adhered to in accordance with our local public health recommendations, and we followed the list of aerosol-generating medical procedures. During the first wave of the pandemic, from March until mid-June, the program fielded 400 telephone support calls, provided 62 essential home visits, and had an additional 447 touch points with clients using a variety of technologies, including video conferencing, email, and text messages. We're going to shift gears now and discuss what some of the preparation for the outreach visit is required for the therapist. As respiratory therapists, we have likely all heard the term point of care risk assessment, or PCRA. It's usually within the first sentence of any document related to providing care during this COVID-19 pandemic. The PCRA is the first step in routine practice. It is performed by all healthcare professionals to evaluate the risk factors related to the interaction between the healthcare provider, the client, and the client's environment. This needs to be done prior to every client interaction in all healthcare settings, whether this be in the client's home, the hospital prior to discharge, or supportive housing. The PCRA assists the healthcare provider in making appropriate infection prevention and control measure decisions for safe patient care and protect you as a healthcare worker. For each interaction, you want to assess the following three things. You want to assess the environment, you want to assess the patient, and you want to assess the task being performed. The risk assessments for those of us doing outreach begins as soon as a referral comes in and an outreach visit is being booked. The majority of the time, the respiratory therapists making outreach visits are alone. So for their safety, there's some baseline information that is helpful to know regarding the environment. For example, is this a single family home or a congregate living setting? Are there animals in the home? Who else will be in the home? What type of parking is going to be available to me? For the safety of all respiratory therapists, they need to assess the environment before they enter, and preparation is key. For our staff who are doing outreach, we need to ensure their cell phones are fully charged in case of an emergency. We have protocols in place so that we know who is out on a home visit and when they're expected back. What level of PPE is required for that visit, and what essential equipment is required to ensure they have that with them. The assessment doesn't stop there. An environmental assessment is required once they enter the residence as well. This is the last piece of assessing. And the environment includes any area within 2 meters of the client, as well as their belongings, and includes things like the washroom and the immediate space surrounding the client that may be touched by either the client or caregiver and the respiratory therapist when providing care or performing tasks. So the second part of our PCRA is assessing the patient. What does this look like in terms of assessing the patient? As per provincial public health recommendations, all clients receive a COVID screening call prior to their home visit. This includes ensuring that nobody else within the home screens positive for symptoms as well. The screening is repeated prior to entering the home. Should either the client or caregiver indicate they are symptomatic, for the client, we will, where possible, provide virtual care and work with our partners to have a home COVID test administered. To date for our program, this has only been required once, and the client had a very involved family physician who went in to perform the swabbing. Within the care environment for that client, we do ask that all caregivers wear a mask in accordance with our local public health recommendations. Now it's time to assess the task. This slide is a bit busy. It's an algorithm that highlights the types of questions we as healthcare providers should be asking ourselves as part of the risk assessment, depending on the task we are going to perform. That specific task will dictate the type of PPE required. Emily will get into more details surrounding the PPE used during our outreach visits for the complex care program. I'm hoping this will have helped you think more concretely about the importance of your risk assessment, how the assessment for you out in the community may look different from that of the point of care risk assessment in a hospital environment. As I mentioned, the virtual visit is an important tool that all outreach therapists should have in their arsenal. Before we discuss how to leverage the virtual visit, let's define what it means. So, what is considered a virtual visit? A virtual visit is defined as two-way digital communication between health providers and their patients that can include emails, text messaging, and video conferencing. Although we used virtual visits prior to COVID, we have really leveraged this tool over the last 9 months. Prior to COVID, we would set up times for face-to-face visits, and on occasion in more urgent situations to facilitate troubleshooting situations by virtual means, to walk clients through a step-by-step approach to problem solve. Well, when COVID struck, it was imperative we follow public health recommendations, which clearly stated to limit any face-to-face interactions. In the very early weeks of COVID, we only went in face-to-face for urgent and emergent issues. This was both for the protection of the client, the caregivers, and staff. Routine face-to-face follow-ups were put on hold, and to be fair, nobody at that time even considered we'd be in this for the long haul. For many, what comes to mind is video conferencing, which is a great tool to have. However, Not everyone has the necessary technology, or for us, many of our clients. They have challenges with verbal communication due to their underlying illness, or for others, the fine motor skills needed to connect to the platform can be challenging. So this can only be used if a caregiver is present to assist. It is imperative to leverage the technology that best suits the client and their needs. It's important to have a menu of options that include low barrier options like the telephone, as there's not a one-size-fits-all approach. For many of our clients who find verbal communication challenging, email and text message is the preferred method of communication. How has the home visit changed? In-person home visits are conducted in a much different manner than in previous years. There's far greater focus on infection control measures for the protection of RT staff as well as the client and caregivers. To keep these complex respiratory care need clients at home, we have empowered caregivers and nursing staff through education on daily IPAC measures to minimize the risk within their own environment. Routine practices continue to apply to all staff during every outreach visit when providing care in the home. This includes conducting a PCRA, regular hand hygiene, and the appropriate use of PPE. As regulated healthcare professionals entering the home, we can use this opportunity to provide education on measures to limit exposure to COVID-19. This includes things like limiting visitors in the home, including staff, friends, family, universal masking for all, closed spaces when performing care, remembering to clean and disinfect all surfaces and equipment used, PPE for all staff or caregivers entering the home, and daily screening for signs and symptoms. Should there be a need for more than one RT to attend a home visit, the staff should take separate cars so they're maintaining social distancing. And if it's absolutely necessary to car share, one of the workers should be sitting in the back seat behind the passenger with the window partly open, and both employees should be wearing masks. So how have things changed? Now more than ever, we have to consider each aspect of our care to ensure protection of ourselves as the RT, but also for our patients and caregivers who are vulnerable. Let's take a closer look at a few considerations for entering a patient home for an in-person visit. We have to consider donning and doffing PPE. How are we going to dispose of this PPE once our visit is done? Weather changes, anything from rain to snow. The importance of universal masking, including caregivers within their own home. Hand hygiene. The importance of limiting the equipment you bring in during your visit. Active COVID screening. I'm now going to hand this over to Emily, who's going to go through the other items on our agenda.
We have all seen the videos and have all received education on how to don and doff PPE in the hospital or various healthcare clinic settings. Although the concept and order may be the same for a home visit, we need to ensure that we all have the necessary PPE for the visit with us. This brings us back to the risk assessment. We almost exclusively require full PPE, including an N95 respirator, gown, gloves, and eye protection, given that the vast majority of our clients are using some form of ventilation or have an open tracheostomy tube. Clearly, PPE has presented challenges for those of us working within primary healthcare and community care. Access to the necessary PPE has been difficult due to the strict allocation of PPE to hospitals and long-term care homes. Accessibility may be easier or more difficult depending on where you live and provincial stockpiles available. Here in Ontario, we faced challenges specifically to accessing N95 respirators. In addition to access, the cost of PPE has risen exponentially, providing real budget pressures for many. In preparation for the home visit, the following surfaces should be cleaned with disinfectant wipes prior to and after seeing the patient. The vehicle steering wheel, gear shift, door handles, both inside and out, window controls, seat belts, mirrors, and any surface that is regularly touched. PPE that could be necessary for the home visit is placed in a plastic container in the trunk of the car, along with a plastic bag for disposal. Disinfecting wipes are placed in the trunk and on the passenger seat, and a bottle of alcohol-based hand rub in the console. All personal items can be locked in the trunk before entering the home to avoid taking them inside. In a community setting such as long-term care or a group home environment, arrangements could be made to have the client brought to an office space or a separate room in a location that is close to the entrance. Although this may not be feasible, larger facilities may be able to accommodate this request. Hand hygiene should be performed frequently and repeatedly as needed throughout the home visit. Although soap and water is the preferred method of hand washing, this is not necessarily available or appropriate in the home care setting. Patients are often set up for an RT assessment to be done in a converted living space or bedroom, and as a result, there is not always easy access to a sink for washing with soap and water. Performing hand hygiene with alcohol-based hand rub, if hands are visibly soiled, will inactivate the virus. When possible, soap and water should be used if hands are visibly soiled. The RT should have easy access to their own personal bottle of alcohol-based hand rub, which can be used throughout the visit, from before entry into the home and upon exiting. Alcohol-based hand rub in a pump dispenser provides an easy and quick means for performing repeated hand hygiene throughout the visit and can be carried in an accessible pocket or bag. Inherently, in-home visits from the RT involve a variety of home environments with different degrees of cleanliness and adherence to current provincial recommendations related to COVID-19. A universal approach to protecting patients, caregivers, as well as themselves, RTs entering a client's home perform hand hygiene at the following points of care. Upon entry to and exiting the home, before and after any contact with a patient, after removing gloves, before and after contact with the patient's environment, including touching medical equipment, beds, tables, or door handles, anytime hands are potentially contaminated after being exposed to blood, secretions, or bodily fluids, before preparing or administering all medications, before putting on PPE, and during the removal of PPE according to the organizational procedure for putting on or removing PPE. Patients should receive education to perform hand hygiene and be assisted with this if they are physically or cognitively unable. Patients should be encouraged to perform hand hygiene upon entering or leaving their own home, prior to eating, oral care, or handling of medications, and after all personal hygiene practices or medical care. For the purpose of our program, the Complex Respiratory Care Program, full PPE is required since the vast majority of our patient population require aerosol-generating medical procedures. We apply the PPE before entering the patient home. Donning PPE during a home visit requires some planning in advance to ensure the appropriate PPE is available at the RT's disposal in their vehicle, and some consideration as to where is the most appropriate location for donning, either at their vehicle, outside of the dwelling, or inside a multi-unit dwelling. Donning PPE outside can have added challenges such as inclement weather in the form of rain, snow, or wind. Finding a place with at least some protection from the elements is helpful. For example, using the trunk space as a surface to gather and organize PPE, the vehicle as a wind barrier, and the trunk or hatch as a shelter. Depending on the entry to the dwelling, this can provide a space to safely don PPE in a more sheltered or covered entrance while remaining outside of the home. If it is undesirable to enter the building without having donned PPE due to extreme unhygienic conditions or lack of ability to socially distance, don and doff PPE in alternate locations such as at the vehicle or outside of the residence. If it is necessary to walk through the building, as in a multi-unit dwelling or group home, consider donning PPE before you enter, as it may be challenging to maintain social distancing in the hallways, stairwells, and elevators. Upon arriving at the destination, in addition to the usual donning sequence for PPE, the following steps should be taken in preparation to enter the home. All items such as keychains and name badges should be cleaned and disinfected with wipes. A key fob and cell phone should be placed in an accessible pocket. Place a garbage bag inside the trunk of the car that can be used for the disposal upon returning to the vehicle at the conclusion of the home visit. Alternatively, this plastic bag can be brought to the entrance of the home. Apply PPE following the usual sequence by performing hand hygiene, donning the gown, mask, and goggles or face shield. Booties are optional based on the home setting. Gather equipment that will be required for the visit, including monitors, stethoscopes, computer, and place them in a disposable plastic bag or one that can be washed with disinfecting wipes after exiting. In order to limit the spread of contamination, we should be mindful to keep hands away from the face, limit surfaces touched, change gloves when torn or heavily contaminated, and perform hand hygiene repeatedly. Let's discuss how we safely doff the PPE at the conclusion of the home visit by the RT. At the conclusion of the home visit, doffing PPE will be done outside of the home or back of the vehicle. When leaving a single unit dwelling, doffing outside of the front door is an option. The RT can use the disposable plastic bag as the garbage receptacle and their own alcohol-based hand rub throughout the doffing sequence. In cases where this is not possible, such as a multi-unit dwelling, the RT will return to their vehicle and follow the doffing sequence there. All soiled PPE can be discarded into the plastic bag that was left accessible in the trunk space. Given the community spread of COVID-19 within Canada and evidence that transmission may occur from those who have few or no symptoms, masking for the full duration of the visit for all RTs providing home care is recommended. The rationale for full visit masking of staff is to reduce the risk of transmission of COVID-19 infection from the staff to patients or their household members at the time when no signs or symptoms of illness are recognized that the virus can be transmitted. To facilitate judicious and effective use of masks as part of source control, family, caregivers, and other staff in the home during the visit should also be asked to wear a mask. If one is not available, the RT can offer a disposable procedure mask. Patients can also be asked to don a mask for the RT home visit, but this is often not appropriate due to the nature of their illness and compromised state requiring our services. It's important to avoid touching the front of the mask or face shield while wearing and removing it. If this occurs, immediately perform hand hygiene. If the mask becomes damaged, wet, damp, or soiled from the RT's breathing or external splash, or if they come in contact with a client, it should be changed at that time. Before entering the home and as part of the risk assessment, the appropriate mask choice will be made by the RT based on the patient's individual care needs and interventions required by the RT. The RT will follow the current infection control recommendations in choosing a mask, either a procedure mask or an N95 respirator. As previously mentioned, most of our procedures involve aerosol generating procedures. Therefore, our practice is to wear an N95 respirator for all in-person home visits. Although this is our practice, this may not be the case for all programs, and the choice of mask will be made by the RT in accordance with their regional public health recommendations. While the patient's eyes are rarely symptomatic in COVID-19 and conjunctival secretions rarely test positive for the virus, the mucous membranes of the RT's eyes may be exposed to respiratory droplets from the patient. Some evidence indicates that with close contact, mucous membranes may be exposed to droplets even in the absence of formally classified aerosol generating procedures. For this reason, eye protection equipment should be used for community care during routine practices when there is a risk of exposure to COVID-19 during a procedure or close contact. Various options are available to the RT entering the home, including reusable goggles or face shields, or alternatively, disposable face shields. Disposable items offer the convenience of being discarded upon exiting the home, along with the PPE, and do not require the RT to clean and store the item in their vehicle. When this is not an option due to access of equipment or the RT's preference, reusable eye protection can be used for the home visit. Reusable items will require disinfecting and then storage for subsequent use. The RT must develop a process to disinfect and store reusable eye protection between home visits. Upon exiting the home and at the conclusion of the visit, the RT can wipe the eye protection with a disinfecting wipe and place it on a clean surface in the trunk of the car. A small plastic bin is useful to disinfect and store this item to avoid damage. To disinfect the eye protection, They can be placed on a clean surface with new gloves applied, and a disinfecting wipe can be used to wipe the outside, followed by the inside with one wipe, and then with a new wipe, the outside can be disinfected again. The surface should remain wet enough to achieve the appropriate contact time for the type of disinfectant used on the eye protection. Gloves should be removed and hand hygiene performed. The eye protection should be left to air dry. After disinfecting, if streaking occurs and this makes it difficult for the RT to see, eye protection can be washed with soap and water or wiped with a clean damp cloth to remove the streaking. In addition to the challenges associated with donning and doffing PPE while in the community, we must also consider how to dispose of the PPE that has been used. Whereas prior to the onset of COVID-19, less PPE was routinely required for home visits, and we could safely remove our PPE prior to exiting the home in most cases. With added precautions as our new routine practice, disposal of PPE should be considered prior to the home visit. PPE can be transported to the home visit in a disposable plastic bag, including the gown, mask, gloves, eye protection, alcohol-based hand rub, and disinfecting wipes. At the conclusion of the home visit, this bag can be used as a garbage bag to gather the used PPE upon exiting the home. When it's appropriate, the closed bag can be left outside of the patient home near the front door for disposal by the patient or caregiver. This allows the RT to return to their vehicle without the soiled PPE and keeps the RT physically distanced from the patient and caregiver when the PPE has been removed. In cases where this is not possible, such as a multi-unit dwelling, or in cases where the patient or caregiver would not be able to collect the waste bag from outside of the front door, the RT will bring the bag of soiled PPE to their vehicle, or follow the doffing sequence back at the trunk of their car using the bag that was left accessible in the trunk space. In either case, the garbage bag can be tied and left in the trunk for disposal. As discussed, single-use disposable equipment and supplies should be used whenever possible and discarded into the waste after each use. Only essential equipment should be brought into the home. When it's necessary to bring equipment into the home, a disposable barrier such as a plastic bag should be used to prevent placing equipment directly onto surfaces in the home and subsequently discarded at the conclusion of the visit. Reusable client care equipment such as SpO2 monitors, end-tidal CO2 monitors, or stethoscopes should be cleaned first and then disinfected after each use with a disinfectant wipe. Key fobs, name tags, computers, and cell phones should be disinfected again at the conclusion of the visit. High-touch areas in the vehicle should also be disinfected to avoid contamination. As much as our profession has been impacted by COVID-19, we must also recognize the impact on our patients and their caregivers. Many patients and their caregivers rely on agency staff to support their care needs in the community and help them comfortably remain at home. As previously mentioned, the widespread shortage of community agency staff has a direct impact on staffing available for home care services, providing care to most, if not all, of our patients. As a result, caregivers in the home are responsible to provide the necessary care for these additional hours each week with diminishing opportunity for respite. At times, services such as nursing or PSW are completely absent due to the shortage of available staff in many regions. In addition, some patients and caregivers choose to decline community agency staff coming into their home when it is available in an attempt to limit the risk and exposure to COVID-19. Once again, the result is an increased workload for the caregiver and the risk of potential caregiver burnout. Many regions, including our own, are experiencing lockdown measures, which can further compound the isolation our families are experiencing. As mentioned, universal masking for all during an in-person visit is the current practice. While most of our caregivers are receptive to this request, they are being asked to follow new routines even while in their own home. Policies and procedures have had to be updated to reflect the current practices focusing on infection control. This is an optimal time for each organization to review their respective policies and procedures. Some consideration regarding each organization's policies and procedures include the following. Ensure your current pandemic plans outline what is considered an essential service. creating your donning and doffing procedures to include outreach, as this process does change, reviewing your client consent forms, ensuring they include details such as consent for virtual visits or corresponding by email indicating risk involved in these forms of communication, updating intake forms to include consent for virtual visits and emails. Of course, we must ensure these policies and procedures meet our college regulatory requirements at all times. As respiratory therapists, this has been a time of reflection and reevaluation of our current practices. We had to adapt to new routines and processes almost overnight in order to protect the safety of our patients and their caregivers, but also ourselves in order to preserve the staffing complement. Since the introduction of COVID-19 into our communities, we have recognized the importance of constant reevaluation of our processes for safety and efficiency. More than ever, encouraging collaboration among all staff and providing the opportunity for the free flow of ideas and knowledge dissemination is important for everyone to remain receptive to new approaches. It's essential to have two-way communication between RTs and the patients and our families to encourage them to share their thoughts, ideas, concerns, or insights. We should take the opportunity during each home visit or virtual care visit to provide and reinforce education regarding adherence to current provincial recommendations. Our ability to adapt together as a profession will be key as we navigate the second wave of the pandemic. Michelle and I would like to thank you for joining us today as we discussed considerations for outreach during COVID-19. We've included our email and our telephone numbers, so please reach out to us by phone or email with any questions. Thank you.